Welcome everyone. We'll just wait a few more moments for people to log in. Okay, I think we'll get started. Welcome again, everyone. Happy April, and I hope wherever you are that you're enjoying some flowers and then watching them bloom. Today we have Dr. Katie Colborn presenting her webinar on palliative care administrative data research. And just a few housekeeping items before we get started. Attendees are muted and video cannot be turned on. However, we wish for you to engage with us by sharing your thoughts in the chat and entering your questions in the Q&A feature, which is a button located in the bottom toolbar of your Zoom screen. Along with our panel, we also have Dr. Christine Ritchie representing the PCRC's Executive Committee. And now I'd like to turn it over to Dr. Ritchie and ask that she please formally introduce our speaker.
Thank you, Naomi, and greetings, everyone. We're so glad you're here for what's going to be, I think, an incredibly informative PCRC webinar, because all of our webinars that are led by Dr. Colborn are informative. Let me just tell you a few things about Dr. Colborn. She's an associate professor in the Department of Surgery and is also research director of the Surgical Outcomes and Applied Research Program in the Department of Surgery at the University of Colorado Anschutz Medical Campus. She holds a secondary appointment in the Department of Biostats and Informatics. And probably most importantly and relevant for our conversation today is that she has been our lead for the Data Informatics and Statistics Core for the past 6 years of the Palliative Care Research Cooperative Group. She's been incredible in guiding and serving as a consultant to a large array of investigators in palliative care. Her research focuses on the development and validation of statistical models for clinical prediction models, reducing infections and health services research. And oftentimes her work involves the use of electronic health records data, machine learning, and high dimensional model selection. Clearly relevant issues when you're thinking about administrative data research. She's also involved in research in improving statistical methodologies for the design and analysis of cluster randomized trials. So as you can tell, Dr. Colborn is just an incredible resource for all things statistics and study design, and we're really glad to have her here with us today. Over to you, Katie.
Okay, thank you, Christine, for that very warm and kind introduction. It's been a pleasure working with the PCRC for the past little over half a decade, as Christine pointed out. And a lot of times we talk about clinical trials, cluster randomized trials in palliative care, for good reason, because these populations, we need to collect information like patient-reported outcomes and things that you don't find in the electronic health record. But there is some robust research going on in administrative data in palliative care research. So I wanted to share some of that today. I'm not an expert in this area, but I enjoyed reading some articles, and I am an expert in the EHR data analysis world, but not so much in palliative care. So really looking forward to anyone who wants to contribute to the discussion at the end, some of their experiences and perspectives on this subject. But what I do want to today is for, by the end of the seminar, for everyone to understand what are administrative data, become familiar with administrative data in palliative care, understand the advantages and disadvantages of using administrative data, and be aware of some useful statistical methods for analyzing administrative data, although don't worry, this is not a statistical talk. I have no equations on any of the slides in this talk. And then know how to optimize collaborative research using administrative data. Next slide, please. So what are administrative data? I gave a talk on this last fall in a data science seminar, and I actually had to look up the definition of administrative data. And fortunately, it's sufficiently broad that everyone on this webinar has probably either used or seen administrative data in their own research. Some examples include data from the US Census, the IRS, electronic health records. But by definition, these data are collected routinely by an organization, not typically for the purpose of research. And next slide, thank you. And so some examples in the type of research that we would be doing would include claims data, for example, from the Center for Medicare and Medicaid Services, the HCUP data or Healthcare Costs and Utilization Project, census data. And I point out census data in health because this has actually been an important source of social determinants of health data that aren't necessarily available in the electronic health record, but can be linked to the EHR to get some of these broader indicators of such as social vulnerability index and poverty. Another example is the National Health and Nutrition Examination Survey. Next slide. And then, of course, we're all familiar with electronic health records data. And these are important because they're typically easy to obtain and very large data sets. They often contain universal codes or naming systems like diagnosis codes, international classification of disease codes that we're all familiar with, common procedure codes, things like that. And then importantly, they can be linked to other sources of data. So for example, registry data, which might have more detailed information on a patient's disease status or comorbidities or important exposure variables. Next slide. The other, as I mentioned, registry data. So some of the registry data that we might use in palliative care would include the surveillance epidemiology and end results, or SEER data set. This is a cancer registry and covers about 35% of the population with cancer. This can be linked to Medicare data. So if you want to evaluate costs, approval for this data set, it does require an application. You do have to give a pretty robust justification for the use of the data. And then you're typically applying for certain types of cancers. So you're not going to get the full data set. You're going to get a subset of the data that is most relevant to your research question. And they're somewhat expensive. So what we've done at our institution is sort of put teams together who are interested in several different modules that they have to offer, and then have a joint application so that we could get 2 or 3 different, you know, like the pancreatic cancer data set and the, I don't know, thoracic data set. So it's a good idea to think about when you are going to apply for some of these registries, to think broadly, because you don't want to have to go through the process again for a second or third hypothesis later on down the road. Another one that we've used a lot at our institution is the National Cancer Database. And this is sponsored by the American College of Surgeons and the American Cancer Society. And it's a clinical oncology data set of patients from about 1,500 accredited cancer centers, and represents 70% of newly diagnosed cancer patients with more than 34 million historical records. And so you can get in this data set a unique site ID for different sites. So you can estimate, you know, is this a high volume center or a low volume center with respect to cancer patients? But what you can't do is figure out what center that was. So they're de-identified centers across the country. Next slide. Another one that I have to admit I don't know a lot about, but I have definitely heard from some of our PCRC members. Melissa Aldridge would probably be the best person from my perspective to ask about this data source, the Palliative Care Quality Collaborative. But it's a national unified data registry for patient level and program level palliative care data. And it includes clinical data, ethical and legal aspects of care, social and physical aspects of care, psychological and spiritual aspects, et cetera. And it's available to participating members. So it looks like if your institution is a member, you can apply to have access to, I'm not sure if it's the raw level data, but certainly aggregate level data and reporting. So this seems like a great resource that I think is still developing. And so I think if you're interested in this, certainly reach out to the PCRC and we can connect you with relevant people who are knowledgeable about these data. Next slide. So I'll give a few examples from the literature. I was actually surprised at how many different studies I found on just sort of my PubMed search, which included palliative care administrative data. And I was also a bit surprised that a lot of the examples are not in the United States, but are in Canada and Europe, different countries in Europe, where I think they have a little bit more extensive data on actually individuals who have access to palliative care. If you've ever worked with EHR data or other types of administrative data in the US, it's actually quite difficult to identify palliative care eligible patients and patients who received palliative care. And a lot of that has to do with the way it's coded in the EHR or how it's billed. So I'll give some examples. The first one, next slide, please, is an interesting study on palliative care in chronic obstructive pulmonary disease. And this study looked at the association between palliative care and rates of days at home, locations of death, acute healthcare use in patients with COPD. And they used administrative data from Ontario, Canada between 2010 and 2017 and matched 1,788 palliative care patients one-to-one with patients who did not receive palliative care using propensity scores on important confounders. And they found that receipt of palliative care did not reduce days at home and only modestly increased the proportion of those who died at home. But interestingly, a response article was recently published that pointed out some of the limitations of their approach and the data source, such as the way that the nursing home patients were handled in the analysis. The authors in the response article felt that actually dying at home, if you're in a nursing home, should be considered dying at home. Another thing they pointed out was that there's a high potential for missing data and especially unintentional exclusion of minority groups who might not have access to care. And then, of course, there's potential heterogeneity across different sites. So this was multiple site data in the way that palliative care is delivered. And I'm pointing out some of these things right now because later on in the talk, I'll discuss some trade-offs, the advantages and disadvantages of using administrative data. And I thought this was a great article because a response article is very likely in an administrative data set because you're using observational data. And so there's a lot of things to consider when you're analyzing observational data. And it's going to be pretty easy for someone to point out some of the shortcomings of using these types of data to come to sort of broad conclusions about, for example, palliative care. Okay, next slide. So this group of researchers from the Netherlands sought to estimate benchmark data actually from large electronic health records data in the Netherlands. And they looked at outcomes that could be improved by palliative care. So they analyzed data from approximately 110,000 patients. and they focused on quality indicators related to place of death, hospital care utilization, and looked at place of death by disease. And so this is a figure from their article, and they show the distribution of location of death by the different disease classes. And I thought this was an interesting article because the goal wasn't to evaluate palliative care, but to evaluate whether you can identify patient populations who might benefit from palliative care. So this was an innovative use of a very large data set. Next slide. So this study was actually really fun to be a part of. This was a study I worked on with colleagues at the University of Colorado, and it evaluated the patient and caregiver support for serious illness, or PASI, which is a per member per month alternative reimbursement structure for palliative care services. And according to Sean Reed, my colleague who was the first author on this paper, this reimbursement model has been described as overly generous by the Department of Health and Human Services. So he developed a modified version, which he called the PASI-F, or flexible. And we actually worked with our colleague at the University of Colorado Denver downtown campus in the Department of Mathematics, Aaron Austin, to do some simulations of different reimbursement structures. And we didn't use fully administrative data here. So what we did is learn some of the reimbursement patterns from the MEPS data, or the Medical Expenditure Panel survey, and use that to create simulations on patients from the statin trial that Dr. Jean Kuttner was a PI on a number of years ago. And the statin data actually are a data set that are available in the PCRC data repository. So this is just an example of how you can combine different sources of data, and you don't even need to necessarily link the data, but learning from one administrative data set and applying that to another existing data set, I felt was a novel way of approaching how we might be able to, I guess, educate people who can make decisions on how we reimburse for palliative care. And this is forthcoming. It hasn't been published yet, but it will appear in the American Journal of Managed Care. Okay, next slide. Another area that I think is really exciting in palliative care administrative data research, and there's a lot out there. So I have 2 articles here, but there's dozens of articles on natural language processing in PC. So NLP, which I'm sorry, I didn't fully write that out. So natural language processing, many of you are probably familiar with it at this point. And there are different levels of NLP. I stole this nice image from somewhere on the internet. You can see the link down there, but classical NLP kind of does this tokenization approach and learns on a clinical data set, does some modeling, and then you get an output that is fairly interpretable and can be used in ways like, let's say you want to identify key terms in your data set that are in the narrative text of an EHR, and you want to use that to create variables that could be added to a regression model. Like, I'm trying to predict whether someone had an advanced care plan, and I want to, and maybe some of that classification is learned by reading the narrative text from the patient's notes. A much more sophisticated approach that people are taking now is deep learning, where you have trained models that are first pre-trained on really large electronic health records data sets. And then you take those pre-trained models and you apply them to your smaller data set, and you can kind of fine tune it a bit, and then you get an output. And unfortunately, the output, although is probably very good at classification, is not terribly interpretable. So there's different ways of utilizing this. We're utilizing this in some of the research I'm doing now with electronic health record related to surgical infections. And so I'm happy to discuss more detail on that. But these two articles here were examples. This group, Linval and colleagues, have done a number of articles. These are just two of their articles, and they have used NLP to identify documentation of palliative care and end-of-life process measures in different populations. So I encourage you to read some of their work where they've applied NLP to the EHR narrative text and have been able to identify some of the things that we just don't traditionally see in the structured data within an EHR. Okay, next slide. And some other recent examples that I just wanted to point out because they were relevant to some of the things that I'm going to talk about later, but also have already sort of covered in this talk. The first one is this study looked at predicting those needing palliative care near the end of life. And what was unique is they used primary care data. So a lot of data you'll see are related to hospitalizations. And that can be a biased data set in that if you're needing hospitalization, you might be a sicker population and you're sort of including a different set of patients in your analysis. So you need to think about sources of bias. This was primary care setting where I felt like you might have a challenge in identifying the data that you're looking for in terms of palliative care utilization, but that your patient population will be a little bit more heterogeneous and have more of the patients who aren't as sick. And the way they actually implemented machine learning here was very unique. I won't go into it in detail. The formulation of their problem I thought was unique in that they defined windows of time where they call sort of the pre-prediction period, where you would look at confounders and comorbidities and exposures of the patients. And then you would have a window of where they're getting near the end of life. And could you actually predict well in advance when that end of life might occur so that you can begin to understand at what point should we start to introduce palliative care to some of these patients. And then the second article was a systematic review that sought to determine if the EHR is actually successfully supporting palliative care research. So they wanted to identify applications, methodology, outcomes, and barriers that would, preclude us from using EHR data in palliative care research. And they found that EHR is underutilized for palliative care. Very few situations where people are using clinical decision support tools in the EHR. Importantly, not many instances where people are collecting patient-reported outcomes within the EHR, and then capturing advanced care plans within the EHR. Okay, next slide. So those are some examples, and I talked a little bit about advantages and disadvantages, but I'll give a broad overview here. And this is really an overview of any use of administrative data for health services research or outcomes research, but particularly with palliative care, because of some of the issues I brought up earlier. I think it's important to think about sources of bias, what's available to us that we're not utilizing now, what are some advantages of using administrative data. So I'll start with the advantages. Obviously, you can get very large sample sizes, and that's uncommon in clinical trials in palliative care. So using EHR or administrative databases is good because we can explore more hypotheses, more stratified analyses that would require larger sample size. Typically, the data are easy and cheap to acquire, but at some institutions, EHR data actually can take some time to obtain. so keep that in mind. And then, as I mentioned before, they often contain universal codes, and I'm going to go into that in a little more detail in a bit. They're publicly available data, so they promote transparency and reproducible research, because if anyone has access to the data, they can do what you did at home. So it's really important to have well-written code, documentation, and transparency in your results. Next slide. So universal coding, what I mean by that is just, within the data sources, there's often codes that you can rely on being very generalizable across institutions and even across the world for the most part. So certainly ICD 9 and 10 codes, current procedural terminology codes you would think would be very universal, but unfortunately some institutions are better than others at keeping track of CPT codes. At our institution, there's always a procedure name. There's not always a code, and the code might change between when the order was sent and when the patient was billed. So careful working with those, but they can be very useful. Medication classes I've found are very useful, not so much the medication RX norm values, which after talking to a pharmaceutical professor, those are not actually useful codes. They aren't easily interpreted. You really should work with the medication, pharmaceutical and therapeutic classes. There's the Unified Medical Language System, LOINC codes, which are logical observation identifiers, names and codes. I've found those to be unreliable in the EHR sometimes. So you'll get a code, but there's some lazy coding that goes on where you can have sort of these broader classes, and each specific code itself may not be specific to the actual lab that was done. So just if you're working with these data, really get to know the data set, because it's not always as straightforward as it seems like it will be at the outset. And then OMOP common data model. A lot of institutions are now doing these OMOP mappings. At our institution, we have some, but there's a lot of missing data. Okay, next slide. So I'm going to go through some mappings, and these are really important. If you're working with EHR data, any administrative data set that contains diagnosis codes, there's a lot of useful ways of turning, 90,000 codes into a much smaller set of useful codes. So the first example is clinical classification software, or CCS codes. And these are a categorization scheme that collapses, over 90,000 codes into 270 unique classes. And the idea is to get, instead of a very specific diagnosis, broader groupings of diagnoses, so that you can think about patients who are similar without having to come up with your own list of codes that would designate a group. This would make it more generalizable as well, because if you come up with 10 codes and somebody else comes up with 15, it's hard for you to compare your results. So thinking about these sorts of classifications, I think can really improve the generalizability of your findings. Next slide. So fee codes are something I actually learned about in the last couple of years, and just really started using a lot in the last year. Fee codes were created by Wei and colleagues at Vanderbilt University in 2017, and they take ICD 9 and 10 codes and map them to a smaller set of categories that they describe as disease phenotypes. And there was a very sophisticated approach to creating these fee codes, and I encourage you to go on this FEWAS resource website and read the articles related to how they did this. But they take the ICD 9 and 10 and ICD 10 CM codes and map them to what they call fee codes. And there's about 1,500 different fee codes. So I gave an example here. You can actually go on their website and use this query to look up different phenotypes, and you'll see what the fee code is for the respective set of diagnosis codes. And you can see here, you can really map a lot of the detailed ICD codes to a single diagnosis phenotype, like here, myeloid leukemia. And this is really useful for a number of reasons. So it reduces the dimension of your data set. You can classify patients into broader disease classes that are more relevant to your research, and it limits the chance of finding false discoveries, especially if you're using diagnosis codes as like predictors in a model. You don't have to work with quite as sophisticated of statistical methods if you can first reduce your data set to a more logical set, rather than trying to sort through thousands and thousands of codes. Okay, next slide. And then another way that you can map these to useful sort of reduced sets is comorbidity scores. So if you're interested in using the diagnoses to estimate whether someone has a comorbidity, many of you, I'm sure, are familiar with the Charlson comorbidity score and the Elixhauser comorbidity score. The Charlson comorbidity index was first developed in 1987 by Mary Charlson, and it's a weighted index to predict the risk of death within 1 year of hospitalization for patients with specific conditions. So there were 19 conditions that were included in the index, and each condition is assigned a weight from 1 to 6, and that's estimated 1 year mortality hazard ratio from a Cox proportional regression model. And then these weights are summed to produce the Charlson comorbidity score. So when you estimate this, you can actually get indicators, binary indicators of different comorbidities, but then you also get a summary score. The Elixhauser score is similar. I won't go into detail on that, but the nice thing is a lot of the software out there. So if you're not doing the data analysis, that's fine, but you should familiarize your team with some of the resources out there. So I provided this link. This is a GitHub page for our package where you can use this comorbidity package and get both the Charlson and the Elixhauser comorbidity scores just by feeding in the ICD-9 codes of your patients. And I didn't mention this, but on the last couple of slides, but they make it very easy for you to do these mappings. So I showed you the sort of visual basic interface on the web for the fee codes, but you can literally download the Excel spreadsheets and merge them into your data. So you have those mappings very easily done for you. And there's code available online. So lots of examples out there, so you don't have to reinvent the wheel when you're doing these things. But the most important thing is that to think about reducing your data, creating meaningful groups. And then one of the things that I found really useful is I'll often work with data that span way back to 2009 or 2013. And the switch from ICD-9 to ICD-10 codes happened around 2015. So if you want to make use of the historical data, using these mappings is really great because you can use both the ICD-9 and 10 code data that get mapped to the same fee code. So the fee code translation to 10 absorb the ICD-9 fee code translation. So you don't have to do any work yourself to do an ICD-9 to 10 transition. That's all sort of built into the mappings that they offer. Next slide. So I've made it seem really exciting, hopefully, to work with administrative data, because I think it's really fun as a statistician to have large data sets with lots of complicated features. But there are definitely some disadvantages, and I'm going to go over those, and I hope it's not too much of a review. If you are someone with an MPH or a PhD, you've probably learned a ton about bias and will be bored with some of these slides, but I'm hoping at least it's a review for people. And I often need to be reminded that I can't just take a data set and run with it, right? We need to think about what is included in our data. Are there real substantial sources of bias, because you want to figure that out before you submit your paper for publication and have a reviewer come back and say, there's bias in your data. There's nothing you can do to overcome that, right? So things to keep in mind are these data are not collected for research purposes very often, right? So they're convenience data sets. They have that certainly exposures have not been randomized. We can certainly look at subsets of the population, but remember, some subsets of the population aren't even there because they have a lack of access to care. So these are things you want to think about, and I'll go into a little bit more detail on bias because I think it's really important. So next slide. So we all hopefully know what bias is. This is something that is inherently in the data that you either need to consider controlling for in the analysis. The only one you can really control for is confounding. Or you need to really think about what are the conclusions I can come to from using this data set if I know that there are some biases in the data, or is there another data set out there that I could potentially source additional information from to find the data that I'm missing in this current data set. So I've listed some sources of bias. If you are interested in reminding yourself about all the many different sources of bias out there, I encourage you to look at this catalog of bias at the University of Oxford. I find it a very useful database. You can literally search the different bias that you're interested in learning more about. But some of the ones that are really important in palliative care, I think I've put here. So attrition bias is unequal loss of participants from study groups in a trial. And this can actually be very true for observational data. So although we have, this existing in a clinical trial, think about the follow-up data on your patients in clinics and how some patients might die and you're hoping to collect some of their patient-reported outcomes, their quality of life. Patients might move away. So those are important things to think about. Is that something you need to consider in your data set? Availability bias, I think, is really important in administrative data, and this is a distortion that arises from the use of information which is most readily available rather than that which is most representative. And so I think actually race and ethnicity are examples of that, because we're sort of whittling down someone's sort of very unique features of their life into a few categories. You have 4 or 5 categories to choose from, and they're not very representative, but those are the choices that we give people. When you link census data, so let's say you're using SDOHs from the census data, you're linking it by their census tract. So if the census tract really isn't representative of the individual, keep in mind that this is not necessarily the best indicator of that particular exposure that you're interested in measuring. There's some other here, but one of my favorites that comes up a lot and always gives me trouble when I'm working with administrative data is collider or collider stratification bias. And this is a distortion that modifies an association between an exposure and an outcome, and it's caused by attempts to control for a common effect of the exposure. So a classic example of this is the obesity paradox, if you've heard of that. And this happens when, for example, you select a patient cohort of cardiovascular patients, and then you want to look at whether obesity is associated with death in that population. Well, and then you're going to control for comorbidities that both cardiovascular disease and obesity share, and death. There's no way to disentangle this, and actually controlling for confounders only distorts the association worse. So the obesity paradox really is a protective effect of obesity observed in certain data sets when clinically it doesn't make any sense that obesity would be protective against death, right? So that's one example, but there are actually many examples, and I was part of a paper once that was rejected by a reviewer because they pointed out that we had serious collider bias in our data set, and we had to kind of go back to the drawing board and rethink the problem. And as someone who's participated in study section, these different types of bias come up a lot in discussion: selection bias, confounding by indication, stratification, and collider bias. These things come up, so really think about it, because there's a number of people out there who are very familiar with these sources of bias, and it's really important to address in administrative data research. Next slide. So I have a few more slides left that are mostly talking about how do we work with administrative data. So as a statistician, the first things I do are, we need to come up with an analysis plan, right? So this has to be reproducible. We need clearly defined inclusion and exclusion criteria. What are the different variables in the data set? How do we map that to our hypotheses? Writing out your hypotheses at the outset is incredibly important. This is because you have such a massive data set oftentimes that you're going to find all sorts of associations, all sorts of significant p-values. So we don't want to do what people call p-hacking and just start analyzing everything and finding significant associations and then write a paper about that. We want to have testable hypotheses, and a lot of times you might want to set clinically meaningful cutoffs rather than using p-values to reject the null hypothesis. This is especially important when you get these large data sets. Almost everything you test is going to be significant. Work with your statisticians to make sure they're writing clean code, making the code available. GitHub is a source that a lot of analysts and statisticians use to share their code. And like, as I said before, because the data are available to anyone, you really need to make this simple for someone to do at home. Next slide. And then in the medical literature, you're almost never going to publish a paper without a strobe diagram if you're using a publicly available data set. So if you're not familiar with that, there's a reference here. On the left is just an example of a strobe diagram. It's like a consort diagram, but for your administrative data. So again, somebody can do this at home. Maybe they don't agree with the exact inclusion and exclusion criteria that you chose, but what's important is that they can see exactly what you did and can recreate the same results that you created. Next slide. And I think one of the difficult things that I mentioned before, but I hope we can discuss a little bit today, is just what are the palliative care outcomes available in administrative data. I can think of some of the ones in the EHR, and many of the publications I presented earlier included some of these indicators here. So home time or days spent at home, number of hospitalizations, documentation of an advanced care plan, location of death, days alive outside of hospital. But what we don't see here are like quality of life indicators, the FACT-G, the FACIT-PAL, things that we all collect if we're actually designing our own study. And unfortunately, they just haven't made themselves available in the EHR or other administrative data sets. So you have to get creative and a thorough literature search. But I think one thing we have to do, I guess, as a group of researchers is try to encourage better collection of PC outcomes in administrative data so that we can do these larger evaluations. Next slide. So do a literature search, not just for outcomes, but because if you're using publicly available data, there's a really good chance somebody already did what you want to do. This comes up a lot when we're working with residents and students who have an idea, or even junior faculty. They have an idea, they see it's available in the National Cancer Database, They want to start analyzing that problem, and then some senior mentor comes in and says, no, somebody's already done that, of course. So really do a thorough literature search. And at our institution, our library is really helpful for this. So I imagine at your institution, the same is true. Next slide. So real quick, computing needs. This is when you're talking with your colleagues. If you're going to use large data sets, and especially if you want to do natural language processing on the narrative text, you might need to set up some cloud computing, some GPU machines, at least a really good computer if you're doing machine learning on really large data sets. So keep that in mind, and those can get expensive, so funding will be necessary for that. Next slide. In statistical methods, I'm not really going to talk about the details of statistical methods, but just keep in mind, if you're working on a clinical trial, if you've done everything right, it should be a t-test or a chi-square test at the end of the day, right? You've randomized out all the confounders. Now you've isolated the treatment effect. Should be pretty easy. Unfortunately, when you're working with large administrative observational data, it's really messy. Somebody's going to have to clean the data, merge different data sources. And then once you're handling the data and doing data analysis, there's so much going on that you're either dealing with high dimensional data, longitudinal data with repeated measures, maybe it's survival data, whatever it is, your statistician can help work through what is the statistical analysis plan for that. But keep in mind, it's going to be a big part of your discussions, unlike a clinical trial where a big part of the discussion is the trial itself and how you're going to conduct that. Next slide. So tips for getting started, define your research question, define your study population, identify potential data source for this analysis, and then conduct a literature review to make sure no one's already done that. Examine the data dictionary. So sometimes it's not obvious at first. It seems like a data set will have what you need, but it's good to check the data dictionary before you purchase the data or downloading it or obtaining it from a particular source, because maybe they didn't quite measure what you needed. And then not all these data are free. Some are. So you might need funding for that. And then you're going to need statistical support. And you'll need funding for that too. So those are things to consider when you're getting started. And that's all I have. And so I'm happy to answer questions or have a robust discussion.
Thank you, Katie. Wow, so many great tips, so many great pearls. Thanks for an incredible session. So there's several questions that have come in, and I'll go ahead and get started with asking them. The first was, could you please share the title of the article that evaluated the quality of palliative care in the Netherlands? I don't know if you know which slide that's
that
on.
title is in, I highlighted it in yellow, and you're going to make these slides available, right?
Yep,
So,
the slides will become available on the webinar.
and that was called Evaluating Quality of Care at the End of Life and Setting Best Practice Performance Standards, a population-based observational study using linked, routinely collected administrative databases.
Wow, a real mouthful. Thank you. And then another question, can you address the issue of the PCZ code being misused in research as an indicator of palliative care involvement?
What is a Z code?
So maybe I can help with this one.
Okay.
So there's Z codes and B codes that have been used to designate as modifier codes to claims data, billing data, to basically connote that a palliative care service has been provided. And I think the challenge that many people have observed is that the use of the palliative care Z codes and B codes have not been consistently used across practices, across health systems, across even payer groups. And so because of that, and I would say when I say not consistently used. I mean, both that people who are providing palliative care are not using them, or that people who are not palliative care providers are also using them if they think that they are providing a service to someone with palliative care needs. So as a result, the inconsistency, I think, has been particularly problematic. And I don't know if, Brian, you want to add anything to that, but that's some of the challenges associated with using those codes. Katie, you want to add anything?
I'll just add that, yeah, this is sort of a common problem across different areas of research. So not just palliative care, but in EHR data, you have to always be cognizant of, is a code not there because the patient didn't have that exposure? Or is the code not there because the patient sought care outside of our institution? Or is the code not there because what Christine just described, people aren't entering it in? And I can give you an example in surgery where this is common. We have post-operative infections like a surgical site infection. A person can actually present at the operation with an existing surgical site infection or sepsis. So that's called a present at time of surgery, or PATOS. And it identifies patients who, we shouldn't really count against the healthcare system that person came in with an infection, but it often just gets double counted as another infection. So the hospital will get 2 counts of sepsis when one of them was just the patient already coming in with sepsis, right? So, but nobody's putting that into the chart. It's just not going in there somewhere. So you have to do things like apply NLP to the narrative text. So maybe if people aren't using Z codes, maybe there's something in the notes. And I think some of the examples of the NLP articles were doing this exact thing, is figuring out who had a palliative care visit. Maybe you can determine that from other sources. So the structured data are what they are. And if people don't enter the information in the structured field, are you either blind to that information, or does it exist somewhere else in the chart that you could use more sophisticated techniques to sort of pull out? That's what we've done as the approach, because certainly you're just missing it. And then you can't really do anything about lack of access to care. So if somebody doesn't have a Z code, it might be because they weren't offered palliative care, so always be aware that there are probably many explanations to why structured data aren't in the chart. I don't know if that was helpful at all. But.
That's great, Katie. Thank you. Just 2 things. First is that I just wanted to highlight that a lot of the papers that you listed are actually papers of people who are members of the Palliative Care Research Cooperative, and many of whom have been a part of the Clinical Trials Intensive, which will be actually starting up next week. So shout out to all of you who have been stalwart members of the PCRC for so many years, and for all of your great work. So here's a terrific question, which is, can you talk about causal inference when using EHR data to compare patient groups and the effect of exposure to certain treatments, i.e. palliative care referrals or et cetera, on certain outcomes?
Yeah. So causal inference is not my area of expertise, but I know enough that I'll just be dangerous here. So with often looking at the counterfactual framework. So you'll say some people got palliative care, some people didn't. What if the people who didn't had gotten palliative care? How much of a difference in their marginal effects, so differences in their outcomes, would we see if we changed their treatment status, right? So what's the average causal effect? And the way you get at that oftentimes is to use an attempt to target the treatment. So isolate that treatment effect. So you'll you'll have confounders, you'll have exposures that are related to the receipt of palliative care. And you really want to see what was the probability of the receipt of palliative care given all these other confounders. And then I can actually estimate the average treatment effect of that. Now, the assumption with that is you've measured all confounders that are related to the outcome that go through the treatment effect. In other words, there's no associations between a confounder that go directly to the outcome that aren't related to the treatment as well. And that's a hard thing to do, EHR data, because of some of the issues I mentioned before, where data are missing, not at random pretty often, so yes, you might have identified all the important confounders, right? But are all of the important confounders actually measured correctly in your population in the administrative data set? So do you know that someone didn't have cardiovascular disease, or was it that they just didn't have a diagnosis of that in their chart? Did someone miss a follow-up visit because they went to another site and so they actually did receive chemotherapy somewhere, but they moved? In Colorado, we actually have this phenomenon often where we get patients from Wyoming, Utah, Kansas coming to our hospital and then going back home. They'll receive some major treatment and then leave. And then we have very little information on them in their follow-up. So we don't know if they're lost to follow-up or they are receiving care, it's just not here anymore. Causal inference can be really hard in observational data because of the many different aspects of the missing data, the way that the data are entered. And so I guess I always caution people on causal inference, whether it's a really clean, amazing data set or not, because of the assumptions underlying your directed acyclic graph. But particularly in EHR data, it can be a problem. But I would recommend reading the literature on this. There's a lot of statistical papers on it, so it's a little hard actually to find applied papers in this area. But if you reach out, I'm happy to try to find some more applied ones. I know of many of the theoretical ones that are probably not that interesting to read if you're a palliative care clinician. So
thank you, Katie.
Yeah.
So we're coming up against the hour, so this will have to be a fairly short answer to this final question, which is, what are your suggestions on how to overcome lack of variables such as quality of life in palliative care research using administrative data?
So I would say, my recommendation is to find the outcomes that are important in the administrative data and use the administrative data to evaluate those. If something isn't there, there's really not much you can do, especially because if you can find it for one person, but it's really hard for most, that means you're going to come to the wrong conclusions, right? So if you don't have a really good measure of your outcome, I would find a different way of ascertaining that information. And oftentimes that means you have to set up your own registry. We have a lot of people in our Department of Surgery who set up their own registries to collect patient-reported outcomes and then link that to the EHR. So
great answer. So if it's not there, it's not there. You may have to set up your own cohort or registry if that's the case. So thank you so much, Katie, for a really fascinating talk with a lot of really great tips on things that you can do to sort of crack the nut of administrative data and especially EHR data. Next month, we'll be talking about, we'll be getting a special presentation from one of our pilot awardees, really trying to understand or to convey all that they've learned from pilot award to where they are now. So it should be really instructive. Look forward to spending time with you at that point as well. Until then, have a great rest of the day, and we'll look forward to seeing you next month.
Thanks.